Welcome, everyone. I'd like to welcome you to our seminar tonight. Thank you all for being here on this beautiful day. My name's Jennifer Rinks, and I'm a member of the Marin Healthcare District Board, and we are presenting this health seminar this evening. We've got a great evening planned to help you learn about new advances in the treatment of hypertension. We've assembled an excellent team for today's session, including Drs. Brian Keefe, Robert Sperling, and Inez Sharifi. Here's a quick rundown of our agenda. We'll kick off tonight's presentation with lifestyle modifications presented by Dr. Keefe. Then we'll discuss hypertension from a patient's perspective, and we'll discuss women's health presented by Dr. Inez Sharifi. This will be followed by a presentation on resistant hypertension, which will be presented by Dr. Robert Sperling. After the presentations, we'll give you an opportunity to ask questions as a group. It's always helpful to hear each other's questions so we can all learn from each other. You'll also be able to meet Becca Pease, our RN and nurse navigator. She will be available to discuss the program, give you tips for taking your blood pressure, and discuss issues related to hypertension. You'll note that we've included materials at each place setting, including a brochure on the treatment for hypertension and a request for more information card. If you want to request more information or provide feedback, you can fill out this form and we'll be glad to have someone call you directly. You are welcome to turn those in to any of our staff members on your way out at the end of the seminar. Most importantly, we want to recognize Sharon Early from the Haynes family. Sharon, there she is. Their family has been so gracious in helping the Haynes Cardiovascular Institute remain at the forefront of the most advanced technology and services available. For any of you who aren't familiar with Marin Health, let's kick off today's discussion with a very quick video about Marin Health.
Here in the North Bay, we like to get lost. But we never lose ourselves. We stay true to who we are and what we believe in, putting our families, neighbors, and community first. So every day we get closer to our best. That's who we are too. And that's why we're here. This is Marin Health. Right here, right next door. Closer when you need us. Closer to your best health. Marin Health. World-class care. Closer than you think.
All right, now let me give you a bit of background about our speakers. We're going to begin with Dr. Brian Keefe. He's originally from Portland, Oregon, and he's been practicing cardiovascular medicine in Marin County since 2004. Dr. Keefe has special clinical interests in preventive cardiology, cardiac CT imaging, and the cardiovascular benefits of exercise. I'd also like to introduce Dr. Inez Sharifi. She is passionate about treating women with heart disease through a comprehensive and evidence-based care. She stays at the forefront of all aspects of cardiac care, from education and prevention to diagnosis and treatment. She is board certified in cardiovascular medicine, echocardiopathy, nuclear cardiology, and cardiac CT. She's received numerous awards, including the American Heart Association Women in Cardiology Trainee Award for Excellence, was a finalist in 2016 for the Young Investigators Award competition at the American Society of Echocardiography, and a Fund for the Future grant awardee from the Weill Cornell Medical College, to name just a few. She's trained at Mount Sinai Medical Center in New York in cardiovascular medicine and vascular ultrasound. We will also be hearing tonight from Dr. Sperling. Dr. Sperling is an interventional cardiologist with a subsequent specialty training in peripheral vascular medicine and percutaneous coronary intervention. He earned his medical degree from Duke University and completed a fellowship at Beth Israel Deaconess Medical Center. Let's give a warm round of applause for our physicians. And without further ado, let me begin by bringing Dr. Brian Keefe up to the stage.
Does it? Okay, perfect. So just to start off with the scope of the problem, blood pressure is something that each of us cardiologists, see in almost every patient every day, elevated blood pressure readings. It's actually one of the most common reason for visits to doctors in the U.S. And, I see this often, people do not have controlled blood pressure, even those we diagnose and we're trying to treat. Despite our best efforts, a good percentage of people, up to half, do not have adequately controlled blood pressure. Not so much anymore, but the term silent killer used to be used quite a bit. I don't say that because it's scary, but it has been called that because a lot of times people don't have symptoms. Up to a certain point, people do not feel high blood pressure. Some people can feel it in their head, or they can just say, I feel when my blood pressure is high, but honestly, I don't believe it in a lot of people unless it's really through the roof. And there are many problems associated. So the actual high blood pressure of 140 or 160 or 180 may not be a problem that day, but over time, the risk is a higher risk of stroke. I tell patients every time the heart pumps, it's like lifting weights. It's pumping against pressure. And I say that it's good to lift weights and make your peripheral muscles strong, but when your heart muscle gets strong, it's not good. It can eventually weaken. So we see remodeling of the left ventricle. We see hypertrophy of the left ventricle, and we can eventually see congestive heart failure. In extreme cases, people can have life-threatening intracranial hemorrhage from very high blood pressure. Coronary artery disease, which is also one of the top few things we treat every day, is higher risk in people with hypertension. And then chronic kidney disease, high blood pressure over time, can affect the brain, the heart, the kidneys, among other organs. So one thing it's useful to think about, and honestly, as I was preparing this talk, I realized, it's hard to do this even in a medical office, how to check the blood pressure correctly. If you think about it, you're going to see the doctor, you come up and, you walk up the stairs. Everyone else says that in Novato. I just walked up the stairs. Come into the office, sit down. The medical assistant brings you in. You're kind of discombobulated. Oh, I'm seeing the cardiologist. I hope they don't find anything wrong. One of the first things they do is check your blood pressure. That's probably not the best way to check it. And so, I'll talk about in a minute. I don't necessarily go off that one reading, but the best way to check it is to sit down, relax, not on an exam table, in a normal chair, put your feet on the floor. You want to do it not having just, walked up 5 flights of stairs, not having just exercised, and not having exercised for at least 30 minutes. Make sure you're not in discomfort because you have to urinate, so use the restroom before you check it. Kind of keep quiet for a few minutes before you check it, so you're not thinking about something stressful, or the blood pressure is very responsive to this type of thing. Check it over the arm directly. I'm a big believer in the blood pressure cuff up here, not the wrist. And even though I may check it sometimes as a second check when someone's on an exam table or lying down, it's really not the best way. It's really best sitting down, relaxed, 5 minutes. Quiet, check it. I really am a big believer in home blood pressure readings, and the data supports that as well. What I tell people typically is check it once a day at a random time. Don't always check it in the morning, don't always check in the afternoon, don't always check in the evening, and just write it down and move on. A lot of people check it 5 times, trying to get it better and better and better. Or they're checking it so many times they get stressed out. Oh, wait, it's a little high. Okay, let me check it again. Then it's even higher again. And I've had people, I have to say, stop. You can't do this anymore. Check it once. Don't close your eyes even, and just have your spouse write down the number, because we're not trying to compete or win a game. We're trying to collect data. So home readings, use that sit down for 5 minutes method. And just check it down, write it down, and we'll look at the data. in terms of how to diagnose it, I think the easiest way is an average blood pressure above 130 or over 80. So I have people bring me usually a piece of paper with a bunch of blood pressure readings on it, and I'll sometimes just plug them into a online calculator really fast and get those averages. I've done it enough I can kind of just eyeball it now and say, okay, it looks like it's averaging, 135 or whatever it is. I've been doing more now 24-hour blood pressure monitors, and the criteria for blood pressure is lower than that because our blood pressures are lower when we're asleep. So if you get a 24-hour blood pressure monitor, it's even going off every 20 to 30 minutes while you're sleeping, and the blood pressures are going to be lower. So the average blood pressure on that type of monitor for hypertension is over 125 or over 75. So in terms of the actual diagnosis, these have changed in my 20-year career a number of times. But currently, and I think what the powers that be do is they keep making normal lower and lower and lower, in part to just make us more aware, which I think is a good thing. So normal is now under 120 and under 80. And honestly, the number of people I see who are over 50 who have a blood pressure less than 120 on no medicines is single-digit percentage, off the top of my head. So it's uncommon, but that's normal. And a lot of people just don't realize that normal is actually less than 120. Elevated now, I think there were other terms in the past. Pre-hypertension was a term that used to be used, is 120 to 129 on the systolic, which is the top number, and then being under 80 on the diastolic. And then we think about stages now, stage 1 and stage 2. So stage 1 is 130 to 139 on the top number, and stage 2 is over 140 on the systolic. And I often use that with patients because I find that the automated cuffs at home are just not as accurate on the diastolic pressure. That's my own experience. But the systolic tends to be pretty accurate. So I usually have people focus on that. The diastolic falls along with it. And then I'll often confirm the diastolic with an old school stethoscope blood pressure in the office. The other thing to remember is if there's a discrepancy, the higher number wins. So if you're 125 over 85, you have stage 1 hypertension. Okay, even though the systolic top number is just in an elevated range. So that's kind of the way I've done it. There was a myth that was propagated kind of in the 70s when there was a study that said that only the diastolic mattered. I can't remember, either only the systolic or the diastolic mattered. So people thought for a while, well, if the top number's high, but the bottom number's no, the diastolic's low, then I'm okay. And that's not correct. Either one. So hypertension, systolic hypertension, diastolic hypertension, they both have elevated risk. We want to think about both. And what are the risk factors? I mean, a lot of these, some are controllable, some aren't. Some of the controllable risk factors are the ones I'll talk about tonight, but advancing age, seeing a 25-year-old with hypertension is unusual and gets our attention, and we start thinking about why. Seeing a 75-year-old with hypertension is common, and we tend to call that essential hypertension. Excess weight or obesity. Certain families have a history of hypertension, and we see that. It tends to be more common in African Americans. Excess salt, excess alcohol, physical inactivity, poor sleep, and some social determinants. So some of these are correctable, and those are some of the things I'll be focusing on tonight. When I see patients, I stole this from someone because I think it's really useful, and this isn't just about hypertension. I think this is about all aspects of prevention. I use it for coronary artery disease all the time, even some types of cancer. I tell people there's certain levers we have to control our health, and part of this is my pitch to try to get people to take medication because a lot of times people don't want to. And I say it always should be all 5. Like, I'm not just saying let's do medicine only. I want you to hit every lever or pull every lever you have to help your health. So for me, and I believe this, that exercise is number 1. And it was mentioned that exercise is kind of my interest and passion. And I'll talk more about exercise, but I think exercise is huge no matter what you're doing. It's moving your body. It's anything that you're able to do. And I'll talk about that with regard to hypertension. A diet is probably number 2. Sleep and stress are huge also, and they're sort of hard for doctors to deal with. If someone says they don't sleep well, it's going to be hard for me to fix that in an office visit, but it's really important. Same thing with stress. But medication is critically important. We'll talk some more about that this evening as well. So it's kind of something that I'll just tell people is, listen, medicines may be part of your treatment, but let's hit every lever we can, whether it's preventing heart disease, it's improving your blood pressure. So to start off with exercise, there's different kinds of exercise, and the medical terms for this are a dynamic, or sometimes called isotonic exercise, and that's like anything like walking, cycling, swimming, elliptical trainer, rowing. Actually, rowing is a combination of strength and isotonic. But that's really what a lot of our data and what I would focus on more with regard to blood pressure. So dynamic exercise. The American Heart Association recommends 150 minutes of exercise per week, which is 30 minutes, 5 days a week roughly, or doing more intense exercise, 25 minutes 3 times a week. I think and the blood pressure lowering you can get from that is about 5 to 8 millimeters of mercury. I'm a big believer in more of the higher volume, lower intensity. So a lot of the benefits, both with blood pressure and heart disease and mortality, quite frankly, is with low intensity exercise. So people, kind of have this notion that they have to go to a gym. They have to run wind sprints or nothing. You don't have to do any of that. You have to move your body. And I think if you don't do anything, starting with 30 minutes, 5 days a week is great. But I tell people with low intensity exercise, there's almost no upper limit of what I would say is bad for you. I mean, if you like walking and you can get up to, an hour and a half every day, great. That's going to help you. Interestingly, and I can't quite explain it, strength exercises have been shown to lower blood pressure as well. So they've actually done it with even like hand grip, just doing that with a hand grip. And I can't explain to you tonight why that might help, but it seems to. So, strength is also really important for fall prevention, for being strong is good. So, incorporating some strength into how you exercise is important as well, and it does seem to help your blood pressure a little bit as well. Balance is also important. I don't think it helps your blood pressure, but balance is super important as well. My big thing I push, and this is, it's really interesting, like the human physiology. There's exercise zones. If any one of us, went into a lab and said, let's push you on a bike or a treadmill from the lowest intensity to the peak, there's exercise zones that we have for all of us. And the benefit, I think, of exercise and also metabolic health, blood pressure is what's called zone 2. And zone 2 is a level of exercise where you could just barely talk to someone. So if you're walking with a friend, you could carry on a conversation. Or I sometimes say if I'm on a meeting, I can be on a stationary bike and I can still talk. I maybe couldn't give this talk tonight in zone 2 because I'd have to breathe a little bit too much, but I could do most of it. You'd know I'm exercising, but I could still do it. And you can imagine if you're exercising hard, you can't be giving a talk or talking with your friend. You have to stop talking. And zone 2 is different from everyone. If you're totally deconditioned, zone 2 might be a slow walk. I listened to a podcast this week with Tadej Pogačar, who's won 3 out of the last 5 Tour de France's, and his zone 2 is 350 watts on a bike. And if any of you are a cyclist, you know how incredible that is. But it's the same physiology for an elite athlete to someone coming off the couch. So I really am a big proponent of just low intensity exercise, lots of it. So moving on to our second lever outside of exercise, it's salt intake. And there's been quite a number of studies showing that there is a drop in blood pressure with reducing salt intake, somewhere in the range of 5 millimeters of mercury on the systolic blood pressure. I think the diet is really, or salt is really hard to measure depending on what you're eating. What I tell people is just as many whole foods as you can. Don't add salt if you can. A little bit of salt with cooking is okay. But there are people who really enjoy salt and are really salt responsive. And I had a patient even today who told me they cut out salt and their blood pressure just plummeted. So really something to think about if you have hypertension is, watch your salt intake, measure your blood pressure, see how it changes, because that's an important component to look at. In terms of diet specifically with it, the one that the American Heart Association has talked about is the DASH diet, and it's a lot of those things. It's fruits, vegetables, low-fat dairy products, whole grains. It's kind of healthy eating and avoiding excess salt in your diet. And as you can imagine, doing a good study on diet is really hard because we're not lab rats. You can't force feed people foods. But the studies that have been able to be done looking at salt and diet do show a drop. So definitely something to think about. Alcohol is another one. For a lot of our patients, I don't think we always take the best alcohol history. It's very common, and I think wine is very popular in this area. I see this a lot talking to people about their blood sugars, and they say they have no carbs whatsoever, no carbs at all, no carbs. I say, do you drink wine? Yeah, I drink wine, but I don't have any carbs. Those are carbs. But in terms of blood pressure, it can definitely raise blood pressure, and usually the threshold, men with a little bit larger body surface area, they say 2 drinks maximum, women 1. And I've certainly seen people who have cut out alcohol, drinking a little more heavily, and their blood pressure is entirely normalized. So definitely something that I think about and talk to patients about. Weight loss is another big one, kind of outside of salt and alcohol. I usually tell people when they're overweight or obese and have a lot of weight to lose, I usually say 25 pounds is worth a med. It can be very motivating for people. I've found that it's somewhere in that range, 20 to 30 pounds. If you're on, say, 3 or 4 blood pressure medications and you lose that kind of weight, I actually want to know about it because people start getting dizzy and they feel dizzy when they stand up. And that happened to me twice this week with patients where they sent me a portal message saying, I haven't seen you in a year. Now I'm getting dizzy when I stand up. And I have them come in for a visit and they say, yeah, I lost 20 pounds. I say, oh, okay, let's stop a medicine. So that's very common. And this is, that graph here on your left shows that, kind of half to 2 millimeters of mercury for a kilogram of weight loss, which is like 2.2 pounds, so that's kind of in that same range I'm talking about. Sleep is something that sleep disturbances of many kinds are very, very common. Again, I think the doctor profession is not very good at assessing this. We underdiagnose sleep apnea, but even beyond sleep apnea, just poor sleep, stress, just not sleeping enough hours, time-starved people in business. We just don't sleep enough in this country. And so whether it's all these things, short sleep duration, sleep disturbances, more common in women than men, sleep apnea, like I talked about, very common and underdiagnosed, and then irregular sleep. One night I stay up till 1 a.m., the next night I go to bed at 10, and then on the weekends I sleep in. All these different things, not getting kind of restful, regular, fairly programmed sleep has an adverse effect on blood pressure. And when I see this, I really try to aim people towards seeing a sleep physician. Even if it's not for a sleep study, it's just taking a sleep history and seeing someone only talking about your sleep, because sleep is really critically important for us. I thought that was a good picture. That was most of us in residency. That's not the type of sleep physician you want to see. You want to see one who focuses on sleep. So stress, another one that is, kind of hard for us to quantify. If I see 20 patients in a day, if I ask, all 20, do you feel like you're stressed? 20 will say yes. I mean, that's 2024 for us. So it's hard to say, okay, well, what's your level of stress compared to everyone else? Because we all feel it, whether it's personal stress, relate with our relationships or family or job stress, everyone has it. But it does definitely impact our blood pressure. If you think back to when we were cavemen, our stress hormones were supposed to be like a bear's coming to eat us, and we run really fast, and then we go back to our, hunting and gathering and, kind of stress-free lives. Now we have bills and computers and, people trying to scam us and, all these different things that are causing huge amounts of stress. And so instead of having peaks and valleys of stress, we have this constant level of cortisol, adrenaline, all these things, and it has a negative impact on blood pressure. So stress reduction techniques have been looked at with hypertension, hard to measure. Again, it's hard to do really good, studies looking at various different stress reduction techniques, but meditation is one that I have a good number of patients who practice. And I talked to one yesterday who said meditation seemed to have really made a big impact on blood pressure. So doing 5-10 minutes of meditation definitely can't hurt. I think it's good in many ways and may impact positively your blood pressure levels. But there's also biofeedback and other options to consider. And the American Heart Association does recommend meditation as a part of a comprehensive hypertension treatment. I'm not going to talk about medications. There's many, and usually a lot of blood pressure with individuals is trial and error. We have ones that we're kind of first line, second line, third line, but every individual is different. And so we try them and we see if it works and if it's effective and doesn't cause side effects. And if it doesn't, we have to try another one. That's common. But what I tell patients all the time is it's not one or the other. Let's use all 5 levers, exercise, diet, stress reduction, sleep, and medicine. And that's how we can get your blood pressure under control. So thank you. I hope that helps. And don't forget to exercise tomorrow. Next, we have Dr. Ina Sharifi, one of my partners, who's going to be talking about hypertension in the setting of women's health and other things. So take it away.
Thank you.
Yep.
Do I need that? Or?
Yes, this is
Okay.
very helpful.
Okay, thank you. All right, hello everybody. My name is Inez. Nice to meet everyone. So as I was trying to put this talk together, I thought what I could do is maybe go through 10 questions that I commonly hear in my practice. And I thought we could maybe go through them. So let's see. First one. What is hypertension? So let's say you take a blood pressure cuff. You measure your blood pressure. It's 140/80. Do you have hypertension? That's the question. So basically me just walking up here to the podium, I'm pretty sure my blood pressure is high right now because I can feel it. But when I stop this presentation, it's probably going to go down. So do I have hypertension? And the question is probably not. Or you come into the doctor's office. You take your blood pressure. Your blood pressure is pretty high because you're coming to the doctor. It goes down right after. Do you have high blood pressure? Probably not. So actually guidelines say, so for you to have the diagnosis of hypertension, it needs to be persistent. What does that mean? So if you have mild or moderate hypertension, so if your blood pressure is around, let's say 130, 140 systolic, it needs to be high persistently for about 3 months. If it's above 160, even one reading, or above 180, then you probably have hypertension. Okay, so that's sort of the first one. Do I have hypertension? And so that's sort of the answer for that. who should get screened for hypertension? Like, should we start, at the age of 2? Should we start at the age of 3? Even in pediatrics, whenever the kids go to the doctor, one of the first things they do in their physical exam is they take their blood pressure. As per guidelines, the U.S. Preventative Task Force basically says that anyone above 18 should be screened for hypertension, okay? And basically in adult medicine. And we shouldn't just use clinic data. We should also use your blood pressure when you're at home, in your own environment, maybe not in the stressful doctor's office. Question number 3. Do I really have hypertension? And I was kind of getting into that in the beginning. So there were a few studies, actually, one in 1990, one in 1993. And when doctors found were that in patients that used to go to their office, if the doctor would say, you have high blood pressure, odds were, when you came to the doctor next time, your blood pressure was 4 mmHg higher. And if the doctor said, listen, you don't have high blood pressure, your blood pressure was actually 8 mmHg lower. So kind of like what the doctor tells you at that meeting also, affects whether or not you actually have high blood pressure. So this is important. And there's also what's called a learning response. So what I was talking about before, you come to the doctor's office, you're nervous. That is basically white coat hypertension. We now think that 25% of patients have white coat hypertension. So that's basically 1 patient out of 4. It's a big number. But our job as doctors is actually to figure out who has white coat hypertension and who doesn't. Question number 4. Actually, this was my clinical example, sorry. So let's say Karen comes to the office because the primary care doctor said your blood pressure is elevated, 145 or 90. She comes to see us in cardiology, and the blood pressure is really elevated. But then she goes to the gynecologist's office, and the blood pressure there is 110 over 70. And then she also follows her blood pressures at home. So the blood pressure at home is maybe 125 or 68. So then when she comes to the next cardiology appointment, we check her home blood pressure monitor. Does it work well? So what's the diagnosis? Basically, Karen's blood pressure is normal. She may have white coat hypertension. And really, it could be that the blood pressure at the gynecologist's office is probably lower because she's less focused on the blood pressure at the gynecologist's office than maybe when she comes to the cardiologist's office. So different doctors' offices can cause different blood pressures depending on how nervous the person is. When should you check your blood pressure? I get this a lot. Do I check it in the morning? Do I check it in the evening? And usually the blood pressure is high in the morning, so the best answer is don't only check your blood pressure if you don't feel well. Because if you don't feel well, it's probably going to be high. But if you feel well, it's probably normal. So what we want to see is averages. So basically, check it randomly, okay? Number 5, what causes hypertension? So let's say we have Claudia. She's a 55-year-old female. She has a diagnosis of hypertension. She's on 3 blood pressure medications, and now the blood pressure is good. And Claudia asks, I eat well, I exercise, I have a normal weight, I do not smoke. Why do I have hypertension? Answer to this is, so in about 5% of cases, we can actually pinpoint a cause. So there's either a problem with the adrenal glands, a problem with the kidney, sleep apnea, or hormonal abnormality. In 95% of patients, we don't entirely know why they have high blood pressure. Okay? Now, it doesn't mean that we don't have an idea what could be causing their high blood pressure, but we don't have an exact diagnosis. So why would they have high blood pressure? And this is where there's this paradigm, the brain versus the kidney. Kidney, 1/3 of the cases, the brain, 2/3 of the cases. So let me talk about the brain. The brain, you all know what the brain is, but then the brain is associated with all the nerve cells in the rest of our body. The nerve cells release hormones, and the hormones affect all the cells in our body. So let's say you're in a jungle and an animal is coming towards you, well, you want to increase the blood pressure because you want to get out of there. And so that's a normal response. That's the brain. You're all sitting right now. So if I said, everyone get up, what would happen? The blood would all pool to the legs, okay, because of gravity. And then the nervous system would say, constrict the legs, okay, to increase the blood pressure. That's also a normal response. So let's say this is the fight or flight response. If you're angry, if you're anxious, if you're nervous, the brain is actually probably making the blood pressure go high. And very often, this is kind of important. If you internalize your emotions, so if you're the type of person that there's a problem and you internalize it, I always tell my patients this, don't internalize. If there's a problem, you deal with it to the best of your ability. Don't hold it inside, okay? So that's the brain. What does the kidney do? So blood is circulating in our bodies. The kidneys are seeing this blood in terms of volume and in terms of blood pressure. If your blood pressure is low, the kidneys say, well, stop, hold on a second. I'm not going to excrete salt. I'm going to keep the salt in the body so the blood pressure can go higher. Or I'm not going to excrete fluid so the blood pressure goes high. So if you're an individual that lives in a tropical climate where you actually perspire a lot and you lose a lot of salt, the kidneys say, well, stop a second. I'm going to retain water. I'm going to retain salt. If you're the same individual, and let's say you move somewhere else, let's say Northern California where it's like nice weather, this advantage will actually cause you to have high blood pressure because your kidneys will retain salt and will retain fluid. And this is about 1/3 of the cases, and this is largely genetic, okay? So this is genetic. So that's kind of the high blood pressure, okay? Why do we have high blood pressure? Remember, kidneys, brain, and then the 5%, probably a condition. So what happens if you have high blood pressure and it's untreated? So we know almost half the population in the United States has high blood pressure. And it's probably one of the leading causes of death worldwide, so in 67 countries. Smoking is the #1 cause of death in the United States, but then, no, I shouldn't say that, sorry. Modifiable risk factors. So if you quit smoking, you really can change your health. #2 is hypertension. If you treat your blood pressure, you can really make a difference in your health. I want you to kind of take a look at this. This is the, hypertension, the bullseye of hypertension, okay? So this is kind of the bullseye. You don't want to be in the bullseye. You don't even want to be in the blue. You want to be outside in the green. So basically, normal blood pressure, 120/80. Let's say your blood pressure elevates a little bit, so you go to the blue area. And I know Robert had a pointer. But let's say you go to the blue area, and your blood pressure increases a little bit, okay? Question that my patients ask sometimes say, okay, so my blood pressure is a little bit high. Let's say it's in the 120s to 130s. How can that really affect me? How long can I be here without any problems, okay? I'll answer that. And the other question is, if you go to the red, that's where really the problems, sort of are. So let me just kind of explain this, maybe in the next slide. If you're in the red, in the middle of the bullseye, but even the orange is a blood pressure greater than 140 systolic over 90, that's where we're talking about definitely medications, definitely lifestyle, but then definitely medications as well. If you're in the bullseye in the red, which is greater than 180 over 120, and you don't feel well, you're probably going to the emergency room. And you can feel dizzy, you can have a severe headache, you can have vision problems, nausea, trouble breathing, or chest pain. If you're in the orange, that's probably medications. Now, in the blue, in the mild, you probably could be there years to maybe a decade, without end organ damage. The problem with high blood pressure is end organ damage, so I'm going to go into that as well. But in the red, there's no study where patients were kept just in the red to know how long it would take for end organ damage, but there were some animal studies, and basically it was a day or two. So after a day or two, you get end organ damage. What happens if blood pressure is not treated? Okay, you have a heart attack, sudden death, stroke, aneurysm, and this is mainly at the middle of that bullseye, especially if you're in the red, where the blood pressure is 180 over 110. Now, the question then, one of the main questions that I also ask are there special considerations in treating a woman with hypertension as compared to a man with hypertension? Up to perhaps 2 decades ago, women were not included in the clinical trials. So data on women was initially in subgroup analysis. So they were subgroup analysis because out of all the patients, the percentage was low in terms of the women included in the trials. Since then, in the last 2 decades, there's been a lot of work on this. And now we do know a lot more about women's health. Hypertension in a woman's life happens a lot, or is very important to consider the life cycle. So we take a look all the way from adolescence to reproductive age, perimenopause, the menopausal transition, and geriatric menopause. So maybe let's go from the end to the beginning. So around geriatric menopause, what we do know is that if a woman's blood pressure is high in midlife, there's a high risk of dementia. So even if you're in that blue or the light blue, it's very important to have a really good blood pressure and good blood pressure control, because that reduces the risk of dementia later on in life. Around menopausal transition, around menopause, what we know is that the estrogen drops, so there's a lot of hormonal changes, and we start to see, for instance, that 80% of women, for instance, over the age of 70, have high blood pressure, even if the blood pressure is normal when they come to the doctor's office, okay? So what that means is 4 out of 5 women over 70 have high blood pressure, even if the blood pressure is normal when they come to the office. And there's also something called a loss of the nocturnal dip. So when we sleep, the blood pressure goes down. With a lack of estrogen, the blood pressure is then high at night. So the blood pressure is higher on a 24-hour cycle. Around the reproductive age, there are a few conditions that are very important. Polycystic ovarian syndrome, where a woman has more than 10 cysts in the ovary, and actually a lot of other criteria as well in terms of the syndrome. But generally, there's insulin resistance, weight gain, and high blood pressure is also an important condition here. Polycystic ovarian syndrome would be 1 in 10 women. So we think that it's not as common, but it's actually quite common. And then around adolescence, the main risk factors for hypertension are, is there a family history of heart disease or hypertension and secondary causes? So let me give you one example here. So let's say SP is a 36-year-old female. She has high cholesterol, increased blood sugars, and a high blood pressure, 138 over 98. She presents with chest pain to cardiology. Stress testing is normal. She's diagnosed with sleep apnea, started on CPAP. And during history, the patient endorses that she's not been having her periods for about 3 years. So then we do hormonal testing and abdominal imaging, and it picks up a 4.5 centimeter adrenal mass. So this is a tumor that releases adrenal hormones and responsible for this patient's high blood pressure. And I can tell you that after surgery, the blood pressure has almost normalized. So out of 3 blood pressure medications, she's now on 1, and she's doing quite well. One thing very important with high blood pressure and heart disease is that symptoms in women can be different. So if there is a chest tightness in a male when you're having a heart attack, women will very often complain of lightheadedness, shortness of breath, maybe pain in the jaw or pain in the neck, but the symptoms can be very different. So it's important for you all to also be aware of that. One question that's really important is from patients, how do I discuss my high blood pressure with my provider? And I think Robert is going to go a little bit into this, but our job whenever we see you is to understand, do you truly have high blood pressure? Number 1. Is there organ damage? Okay. Number 2, Do you have other risk factors? So if you have other risk factors, your risk is higher from hypertension, so we're more inclined to treat you. And then we treat with medication. So what are some patient concerns about medications? So perhaps one important thing is that there is a mistaken belief in patients that if you feel well, hypertension is not harmful, okay? And we understand that. But it's actually a mistake, as some of the talk has described today. And some people are not taking medication as they're not aware that they have high blood pressure. So number one is you measure it, and you make sure that you know you have high blood pressure. And the other thing is, from a doctor's perspective, and also from the patient's perspective, it's difficult to take a medication every day, for instance, when you don't have physical symptoms. We understand that, okay? And then most of us probably don't want to be reminded every day that you have a potentially, dangerous illness, right? And you take medication for it. And probably one important thing is that we also understand that except that at 5%, 95% of patients, in a way we have to learn to live with hypertension because the medications, they're not really a cure for hypertension, they're treatment, okay? So this is from the patient's perspective. What are some misconceptions about medications? So one misconception is that maybe one medication lowers the blood pressure more than any other. Truth of the matter is, all medications will work in about 50 to 60% of patients. There's also a mistaken belief, and there are trials looking at different medications and et cetera, that one drug can save more lives than any other. Not entirely true either, okay? And then there is a mistaken belief that all medications work the same, work in the same percentage of people. Whether or not you respond to one medication has very little bearing on whether or not you respond excellently to another medication. So basically, treating hypertension is also an art, meaning we have to find the correct medication for each patient. And truth of the matter is, for instance, women have a higher degree of side effects. So the doctor's job, in a way, is also to make sure that they find the correct medication for you from a long list of medications, but also to make sure that they find the right medication for you with the least amount of side effects. And then last point. So if you leave this, leaving this presentation today, what are 3 things that maybe you should walk away from that I thought were important? Even though it's not used anymore, the silent killer, I think don't wait for your yearly checkup to kind of know what your blood pressure is. Take it at least once a week, in a very calm environment, just to make sure that your blood pressure is in a normal range. We discussed lifestyle modifications, but truth of the matter is they probably work in about 20% of patients. So 80% probably will need a combination of lifestyle and probably a medication that is right for you. And maybe the last thing is that the medications are a treatment, they're not a cure. So work with your doctors, figure out, are you in that 5%? Okay? And then try to figure out what the right medication is for you. Thank you very much.
Cool. It says Extreme Productions on the back here. We're having an extreme production. How's everyone doing? Okay, does anyone need to stand up and stretch, or you doing okay? We'll move on. My name's Robert Sperling, and thanks so much for coming and joining us tonight, and thanks to my colleagues for participating as well. There's so many comments that came up watching your presentations, and that's not necessarily directly related to my talk, but just a couple comments. So just to know that, we're not thermostats, and we can't just sort of dial a blood pressure of 120/70, and blood pressure moves around all the time. So that's how nature is. It's messy. So we need to realize that, blood pressure is going to move around from time to time. We want to check resting blood pressure, which doesn't mean while we're sleeping, but when we're relaxed. Blood pressure goes up, as Dr. Sharifi said, normally if you're nervous. When you exercise, blood pressure goes up. That's okay. That's normal. A couple other things that's really important. Write down questions you have for your providers. about your medication if you're taking medication or if you need medication, and medication should be, if you're taking medication, simple as possible, once a day. If you're given a drug that's 3 times a day and you can't take it 3 times a day, really important to tell your provider that, and just have open communication with your provider. Those are a couple of things that came to mind from your talks. The other thing is that when we're looking at, what's the effect of salt reduction, and the average was like 4%. And I'm going to talk about treatments and renal denervation and what's that, and I'll give you an average blood pressure. That's across a population, but we're all different. So some of us may have a dramatic response to cutting back on sodium. Some of us may have none. So some of us may do well with one medication or have no effect with another. So just important to think about when you are managing this condition of hypertension. So just an outline of my presentation. I'm gonna focus on just a few basic facts and definitions of hypertension. We're gonna go through real quickly on that. Challenges we face treating hypertension, how to approach the challenges, and a new treatment option of renal denervation. So why is hypertension a major health crisis? Because 50% of the US adult population has it, and that 80% of those with hypertension do not have their blood pressure under control. Yet it's the number 1 leading preventable cause of heart attack, stroke, and death. And a fact is that 50% of folks given blood pressure medications become non-adherent within about a year. It's difficult. So we saw this, we become more aggressive with like what's normal blood pressure, but not to, where normal is now less than 120/80, who's that? Not many people. It's important though to take hope, because reducing office blood pressure by just 10 millimeters of mercury can lead to meaningful reduction in clinical events. So if you're not perfect, you're still better, your risk is still going down, take a deep breath. There's relative risk reduction by dropping your blood pressure 10 millimeters of mercury. In heart failure by 28%, in stroke by 27%, coronary artery disease by 17%, and all-cause mortality by 13%, just with a 10 millimeter drop in the top number in an office setting. What are our challenges? Number 1 is simply recognizing it exists. You've heard about that. How do we do it? And if your blood pressure is high in a healthcare provider's office, don't wait a year to check it again. Other challenge, lack of motivation to treat it. Usually we can't feel hypertension. Treatment doesn't bring immediate relief. I would also say that although when sometimes we're saying we feel hypertension, I think what's the chicken and what's the egg? If your blood pressure is 180/120 and you're feeling poorly, it's probably the blood pressure. If you're feeling poorly because you're feeling sick and your blood pressure, or you're stressed, your blood pressure is 150/90, I can feel it. You're not feeling your blood pressure, you're probably feeling stressed, which is raising your blood pressure. But there's a lack of motivation to treat it because it's not like, I'm sick, I need an antibiotic. Lifestyle habits to control blood pressure can be challenging to achieve, Dr. Keefe. Routine exercise, maintaining a healthy weight, heart-healthy diet, these are difficult. So limiting salt and alcohol intake. And it's difficult taking medication. Cost, potential side effects, reluctance to take medication. And as Dr. Sharifi alluded to, one challenge is when there's what we call secondary hypertension or some underlying clear cause like an adrenal tumor or something affects 5 to 10% of patients we see. So that underlying problem can sometimes go unrecognized. Dr. Sharifi talked about secondary causes. We'll just skip that. When to suspect, do I have something else going on? Is there some secondary hypertension that needs to be fixed, or is it just run-of-the-mill, what we call essential or primary hypertension? So if you have hypertension diagnosed at a young age or suddenly at an old age, if you have sudden onset of hypertension, if your blood pressure was well controlled and suddenly it shoots up, or if people have a very low sodium level in their blood, there might be some adrenal issue going on. Substances that may increase blood pressure, really important to look at not just sodium, but alcohol, amphetamines, either for ADHD treatment or recreational, certain antidepressants, excessive caffeine, so limit your intake less than 300 milligrams a day. I'm looking at the espresso guy. Steroids, decongestants, that's me too. Decongestants, herbal supplements, some oral contraceptives, and some people respond when they're taking Advil, ibuprofen, Celebrex. These things can raise your blood pressure, as well as recreational drugs, cocaine, or amphetamines. So approaches to treating hypertension, we talked about lifestyle medication, remove causative medications or substances, treat underlying causes if present, and again, that's uncommon. Know that adequate control may require multiple attempts with different combination of medications and multiple visits to providers. And then we consider renal denervation. What's renal denervation? So just Dr. Sharifi kind of mentioned, but the kidneys modulate the sympathetic nervous tone via the renal nerves to control blood pressure. And in some patients, that's kind of overactive. And if we can disrupt the renal nerves, that may help lower blood pressure. This is a pathologic slide. This is a right kidney. This is the aorta. And this lace-like white structure are the kidney nerves, actually. So the artery is here, and the kidney nerves are right outside the artery. So in the 1930s, looking back, surgeons began severing those nerves with an open surgical procedure, and it was effective in some patients. Very morbid procedure, sometimes with good effect. Renal denervation, which was just FDA approved here in November 2023, is a minimally invasive procedure to calm the kidney nerves that affect blood pressure. It's used as an adjunctive treatment, not instead of medication or lifestyle modification. And we think about it when lifestyle changes and blood pressure medications do not adequately control blood pressure. This is gives us just a cartoon of the catheter itself. This is the tip of the catheter. This gives you a sense of the size. So there's 4 electrodes on the tip of this catheter that we insert through the femoral artery up the kidney, up the aorta into the kidney artery here. And the electrodes lie up against the inner lining of the artery. And it delivers targeted radio frequency waves that causes the fat outside the kidney arteries to oscillate, and it heats up the nerves. That's where the nerves run in the fat. So it preferentially affects the kidney nerves, not the kidney artery. And this just shows you what we're looking at in the cath lab on the right here. This is a fluoroscopic X-ray image. This is what we see. The X-ray dye shows us the branches, and we move this catheter around into the different branches. The procedure takes about 1 to 2 hours. Patients get what we call twilight sedation, not general anesthesia, but just to help people relax. It does not leave a permanent implant behind, and the effect is independent of patient adherence. You don't need to take your renal denervation every day. It's one procedure, and then the effect may or may not be very effective. Most patients remain on multiple medications after the procedure. Some may have a reduction in the dose or the number, but generally it's to help control blood pressure. That's the point of the procedure, not to get rid of medications. That's unlikely to happen after a procedure. Not a magic wand, but very interesting technology. So just quickly to look at the spiral program, the Symplicity spiral catheter, and there's the program trial data. It's complicated for us to understand, so bear with me here. But there's 2 trials initially. This is the spiral hypertension off medication trial. So these are patients who were not taking medication, and they were treated in the light blue. This is treatment. In the purple was sham, so patients actually had a catheter inserted, but they didn't have the procedure done. And on the right, this was, who would sign up for that? That was before that was FDA approved and you could just get the treatment. They randomized patients. So this on medication, these are patients who are already being treated with medication, and this is the renal denervation versus the sham procedure. And in general, there was about a 9 millimeter reduction in the blood pressure with treatment, whether you were taking a medication or not. This wasn't a completely fair comparison in the trial because the patients who had renal denervation had fewer medications, 20% fewer medications at the 6-month mark. But this was enough to get the procedure FDA approved. In real world life where people were treated, thousands of patients were treated, this is registry trial data, meaning they're not randomized, they're just, we're going to treat you and we're going to watch your blood pressure. And so about 3,000 patients at 6 months had a 13 millimeter drop in blood pressure out to 3 years, where it's about 17 millimeter mercury drop in blood pressure. Long-term follow-up in different locations in Australia and 2 sites in Germany, at out to 9 years, we're seeing between 10 and 16 millimeter drops in blood pressure. And so again, sort of the concept of, okay, well, if the average drop in blood pressure is maybe 10, is that great? It's important to know that not everyone's going to respond, and some people are going to respond very dramatically. And we don't know how to predict it yet, who's going to respond, who's not going to respond. So about 61% of patients had more than a 5 millimeter drop in blood pressure. About half patients had more than a 10 millimeter drop in blood pressure. About a third of patients had more than 15 millimeter drop, and then there's 25, a quarter of patients had more than 20 millimeter drops in blood pressure. The effect is always on. I'm not going to go through this, but the point is that the effect throughout the 24-hour cycle in these patients we follow so it's not just certain times a day where the renal denervation had an impact. Safety, we can see there was 1 patient out of 253 in this trial that had a complication that was a vascular injury where the procedure was done, but there was no renal failure, damage to kidney arteries, or any other untoward events. This shows us that it's safe with regard to the kidney function. These are patients up here who had normal kidney function at baseline before the procedure and 3 years later. And these are patients where they have reduced kidney function, had the treatment baseline out to 3 years later. So it seems to be safe in patients with and without kidney disease. And some takeaways from the spiral renal denervation studies is that basically there's a significant blood pressure reduction compared with those who got the sham procedure in patients with uncontrolled blood pressure. It's safe and has a sustained effect out to 9 years. So finally, when do we consider renal denervation? If you have uncontrolled blood pressure, taking multiple medications, or if you're intolerant to medications. I had a patient who couldn't tolerate any medications. He's just taking 2 at low doses, and the procedure thus far has been very effective for him, surprisingly, and very happy for that. And also patients who are willing to undergo an interventional procedure, of course. The goals of renal denervation are to optimize blood pressure control, not so I can stop all my medication, because that's kind of rare where we see people coming way off medication. And I think I already mentioned, what to expect, and that it's difficult to predict who will respond. We do tend to see the magnitude of reduction in the blood pressure is proportional to the baseline blood pressure. So if you're starting with higher blood pressure, we seem to see a bigger drop in blood pressure. Thank you.
All right, well, now we are really going to have another opportunity to answer questions. Thank you, Dr. Sperling. So I believe this gentleman over here had a mic a few moments ago, and I think the mic's coming back.
I have a loud voice, if that helps.
Let's just give it, you might have a loud voice, but not everybody's got great hearing, so let's just give it 1 minute. Here comes the mic. Oh, Jill's hustling over there. Okay. Oh, well. All right, we were going to go to this guy who had the question before when we cut off. So let's just go to him. She's got a mic right there, and then you'll be next.
It's on?
Yep.
Okay, thanks. How much does high cholesterol come into play with all this, or does it? Is it 2 separate issues, or does it affect high blood pressure, and how does that work?
I'll take it. Yeah. So if you also have other risk factors, so high cholesterol, maybe some of the other risk factors we talk about, we are actually more likely to treat even when the blood pressure is maybe mildly increased, okay? Because there's a lot of protection. So I think I had one of the pictures that maybe I had on the slide is, so let's say if you have high blood pressure, so the vessel there is a tunica intima, it's called. There's a layer. So the vessel has layers. The inner layer is very thin. So if you have high blood pressure, what happens is it destroys a few cells there, it makes a hole. So if you on top of that, you will have high cholesterol. What happens is the cholesterol gets in that space, okay? And then the body adds clots, white cells, inflammation, and then you get a plaque there. So then the plaque is more likely to cause a heart attack, okay? So that's why maybe high blood pressure and high cholesterol go together. So if you have high cholesterol, and let's say your blood pressure is maybe mildly increased, we're actually a little bit more inclined to be a little bit more aggressive just to protect your cardiovascular health in the future. Okay, so I would say that's probably that. Yeah.
Okay, so let's go back here, and then we're going to come up front again. Yeah, back there by Jill.
I hope that
My
answers.
question relates to alcohol. I can intuitively appreciate salt and getting rid of that, but I don't understand the blood chemistry or whatever it is around alcohol. Can someone explain what does alcohol have to do with blood pressure?
Okay. Who wants
Yeah,
that one?
honestly, from a kind of scientific perspective, how that's affecting the blood vessel, I can't tell you. I can't tell you how it does. I don't know if it's, it's probably multifactorial. It's probably, carbs, weight. But I think, alcohol is, and this is not like having a single drink. It's multiple drinks that affects it. But alcohol, at a higher level, more than 2 for men can be toxic to the heart, the liver. And I don't know, I can't tell you if it's directly affecting somehow the elasticity of the blood vessel or exactly what it's doing. A lot of this is just based on kind of studies looking at it, saying, and a lot of these, again, we're not lab rats, so we're not like force feeding half people like, wine and half people
No
a
random
placebo
science.
that tastes
Right.
like wine. We're looking at, like surveys of how much do you drink, what's your blood pressure, that type of thing. So they're not perfect studies.
Okay, over here and then in back.
I'm just wondering, why do women tolerate the medications less than men?
Yeah. Maybe I'll take
That's
that.
your
Yeah.
question. My answer is I don't know. Yeah.
Well, so it kind of depends on the medications and if they're, let's say, water soluble or fat soluble. And so when you look at the kinetics of a medication, like the pharmacokinetics and how long, for instance, it takes for a medication to reach steady state in the human body, usually it's like 7 days. But let's say if it's fat soluble, generally women have lower body weight. So basically the percentage is lower, number one. So the medications have, the medications can, if they're cleared, even if they're cleared by the kidney, but just by virtue of where they're dissolving, the concentration can actually be higher. Women are generally basically lower body weight, and so that's sort of one of the areas. Yeah.
Okay, back here.
We have a question here.
You mentioned that hypertension is one of the leading killers in the United States. Are there any countries that don't have that as an issue? Western civilized countries, I'm talking.
All right, who wants that one?
I actually don't know.
I don't know the answer
Yeah.
to that.
I mean, some of the data was like the entire world, giving you like but I don't know what cultures, I haven't been a cardiologist in that country yet. Good question, though.
We can get back. Actually, we can get back to you on that.
Yeah,
we
that
can
is
find the answer. Yeah, we can find the answer. Maybe we'll get. Yeah, we can. Yeah,
I'll be glad to.
we'll get our information. We'll get back to you on that. We'll find out.
Okay, and then over here.
I'm wondering if you can discuss the relationship between the systolic and the diastolic. As an example, in the morning I'll take my blood pressure 127/79. After I take my medication, it can fall down to, let's say, 117, but over 69. Do I have a problem with the diastolic?
I can take that. So, I mean, the normal, say if we take a normal blood pressure, 120 over 80, the pulse pressure, we call it, is that difference between the systolic and the diastolic. The pressure that we measure, if we put a catheter in the aorta, which Robert does when he does procedures, or we put a catheter in like one of the peripheral arteries, with each heartbeat, when the heart is squeezing, the left ventricle, the systolic blood pressure, the heart squeezes, and that's that top number when we're measuring pressure, and then the lower number is the diastolic. So it generally, they do track together, and I think particularly on a home blood pressure cuff, the numbers are close, but they're not perfect. I don't think any of us can even explain how a home blood pressure cuff works. I tend to really, I check almost everyone's blood pressure with the old-fashioned stethoscope, blow up the cuff, do it that way. But there are a lot of things that can change one number versus the other in individuals. Sometimes valvular heart disease, leakage of certain valves can cause that pulse pressure to be wider. People with, older people, and I find actually one of that question about women, thin, older women who don't tolerate medicines, I think often have very inelastic small blood vessels that really respond a lot to medicine for some reason. I mean, that's not scientific. That's just been 20 years of, that seems to be the people who I really struggle with. So there's a lot of people there's a lot of things that can change those two numbers, but I think the two numbers you gave kind of make sense to me. 127 over 80 and 117 over 69. I think that's what I would expect. If the systolic drops that much, then the diastolic is going to drop along with it.
Okay, before we go over here, is there somebody else who's got a question too, so we can get another mic lined up for the next one? Okay, go ahead, sir.
Is the treatment for the risk factors for hypertension for poor sleep and stress part of the cardiologist's treatment plan? And how is it treated?
Will?
I can answer a little bit, and you
Perfect,
can follow up. We're not well set up to treat sleep, but we have colleagues who, sleep medicine is a field in medicine now. So, so I do a lot of referrals for sleep medicine, and what's interesting is technology is allowing sleep medicine to advance. So I've sent some people to a sleep physician in Los Angeles who uses kind of a tricked out Oura ring, like a ring that you just wear to sleep for a month, and they look at your sleep, and then they do video consultation with you about your sleep. So we refer for sleep, but we're not trained in it. I wouldn't be able to advise well on it. In terms of stress, we can talk about it in our post heart surgery, heart attack program, which we call intensive cardiac rehab. That is a component of it, that stress is actually treated and instruction given for that kind of select group of people who've gotten to the point where they've had a clinical event. And so meditation, Tai Chi, things like that are part of that program. But just on a day-to-day, sadly it's not covered. We don't have the resources. We can say, listen, you should seek help for your stress, but we can't treat it ourselves.
But you do the referral, and it's part of what would be a treatment plan for hypertension.
Yes.
Thank you.
Okay, over here. There.
I have a comment and then a few questions for Robert. I can easily understand why patients are concerned and question, like this gentleman back here who wants to know what his true blood pressure is. You put up numbers, and we're looking at numbers, and we know that if it's above 120, if it's 140, and patients need to understand it's kind of like heart rate. It's, your heart rate varies throughout the day. Your blood pressure varies throughout the day. When you bring in a list of blood pressures to the doctor, he's looking at 100 readings, and in his mind, he is averaging it out. But you have to understand that blood pressure is a moving target all the time, and that's the challenge. It's difficult for patients. I think one of the most important things about managing blood pressure is educating the patient. It's a hard nut to crack, all the way from the beginning where I have no symptoms, but I'm at risk. I don't understand that. So it's a difficult problem for patients to really recognize what hypertension is and how important it is to do home readings. That's the most important thing. And then in terms of your procedure, Robert, this renal denervation, first, what I heard was that you have no insight into which patient is going to respond the best, except those with high blood pressure, the highest blood pressure, do the best? At this point?
The scientists, not me, Dad. The scientists don't know.
Don't call me Dad.
No. We're looking. There's no. You'd think like if we found like higher amounts of cortisol or higher amounts of something produced by the kidney, that renal denervation would be right for those patients. More studies to come, but we don't know.
Okay. Second, can you explain why this procedure was undertaken more than 20 years ago, and why has it taken 2 decades to suddenly be approved?
That's a political FDA question. Why were they doing it? And like, when did they start doing transcatheter aortic valve replacements in Europe? How many years before we were doing it here? They've been doing renal denervation elsewhere for 10 plus years, and we just started, because FDA approved it. Can I tag onto that comment real quick?
Sure.
So thank you for your comments about treating hypertension and how difficult it is. I do want to say, because, so I'm now the medical director of the Haynes Cardiovascular Institute, which is the philanthropic arm of our cardiovascular program. And this was gifted to me by my father, who's pummeling me with questions here.
Just for
I
context.
don't see any
for
humor in
everybody.
that. I have one last question, which is...
Wait.
He was just
I'm not done.
Our time's running out.
No. So I will get to your question. But I want to actually point out that we appreciate everyone's support here, and we cannot actually do what we do here without philanthropy. And that when I trained, I just figured you show up and the hospital had all the equipment you need and you did your best for your patient because hospital just made it so. And that just isn't the case. About 50% of the equipment we have is in partnership with philanthropy. And we were, in terms of renal denervation, got approved in November. And several weeks later, we were the first center, not in a research center, but a first commercial center west of the Cleveland Clinic to perform the procedure here. Why? Because of philanthropic support and because of our partnership with administration. I think Dr. Klein pulled a few strings, and so we're really proud of that. But I just wanted to thank you for allowing us to do the work we do, but you, Dad, but also the community for your support, and Sharon and your family. Thank you. Yeah.
All right.
Your next question?
Okay. And let's keep it short because we do have others.
Technically, I just am interested in knowing when you do the procedure. I mean, is this radio frequency energy that you're using?
Yeah.
So, what's your endpoint? And I presume you go into multiple arteries.
Yep.
And is it just a certain amount of time you're delivering this?
Exactly. It's a minute each time, and the computer. There's literally a console that tells us how much RFA is being delivered, and it'll stop when the.
So, is there any way of really knowing if you're deadening all these nerves?
No. Yeah, there's no what's the feedback? Nope, you just do the procedure. There's
Okay.
no, yeah.
Okay, I'm done.
That's a holy grail.
All right. I think, does this gentleman over here?
Sir, do you want
Sir, are
to
you-
ask a
I think
question?
we're ready now.
Okay.
Let me, maybe I'll tell you about another actually maybe imaging that Robert does, the renal artery ultrasound.
Yeah.
We should probably talk about that a little bit too. So there is this condition where you get stenosis of the renal arteries. Like we just talked about how important kidneys are. So if you get basically, and we just took care of a patient like this, so if you get blockages in both of the renal arteries, the blood pressure can really go high to the point that you don't excrete anything. Blood pressure can be really high. You can be in the ICU, very short of breath. And so one actually procedure that also, in addition to renal denervation, that Robert does is IVUS, intravascular ultrasound. So he'll go in with ultrasound, take a look at the renal arteries to make sure they're not blocked. So this is also very helpful, actually. It's very helpful in patient management, in addition to the renal denervation procedure.
So if somebody does have high blood pressure, do you also check their kidney function?
Yes.
Okay. All right. And all right, we're going to go back there, and then we'll come to you, Sharon.
Okay.
Oh, we got one more back there.
Hi. I know you've addressed issues of relaxation and meditation to bring down hypertension, but I think that your ignoring one. I don't mean to be funny. It actually works for me. It's a golden retriever. And to get out of your own head and relax matters. And I guess I don't have medically, out of the roof hypertension, but it really helps. And my guess is that there's a lot of people in this room that are not medically through the roof and are sort of tense. And I think I chose a golden retriever. I think there are other types of behavior that one can help oneself. And it would be interesting to hear a lot more of that. I recognize you're doctors and you're financially invested in what you're talking about, but, how about it?
Anybody want to comment on that?
I think you mentioned that
Yeah.
about stress reduction.
Yeah, no, I think stress reduction isn't just seeing a doctor. I think a lot of it is exercise, enjoyment, enjoying life. I actually didn't see anything on dogs.
Well, walking the dog.
Blood pressure.
You have to
Actually,
walk
I have
the
a golden
dog.
retriever who
The
would
opposite.
raise your blood pressure.
That was my chihuahua.
But that's rare. My other two golden retrievers prior to him were blood pressure lowering golden retrievers. Now I have a blood pressure raising golden retriever. But yeah, I think things that make you happy and relaxed lower stress levels, lower those stress hormones like cortisol and adrenaline that are running too high in all of us. So I think that's true.
Okay, Sharon had one, and then we've got one over there. So go ahead, Sharon.
Mine is very quick. You recommended 150 minutes a week of moderate
Mhm.
exercise.
Mhm.
Is that age adjusted, or is that everybody?
No, it's not. It's not age adjusted. But I don't say go from 0 to 150. And I think what a lot of studies have shown is something's better than nothing. So if you're even doing like when I go to the store, I park 3 blocks away and I walk to the store and back, and say that's 7 minutes, 3 times a week. Even short bouts of exercise help.
Yep.
So there's I think more is better, but anything is better than nothing.
Okay, we've got somebody over there, and then we're going to come here, and then if somebody could get the woman in the way back a mic, that would be great. So over here.
I wanted to add to that golden doodle also. Except now that she's turning 15, it's getting to be a tiny bit stressful. Anyway, the reason I'm asking this question is my cardiologist, who happens to be here, had asked me to do a study of my blood pressure, at which point I brought in my cuff like I was asked to do, at which point he was holding it over the trash can, and I said, no, don't do that. Which ones, and then I called Omron in this particular case, and they have a 10% change, which means it's actually 20%, so it's either direction. What do you guys recommend that we would get to actually do a good job of giving you a list of our blood pressures?
Are you asking what's the right blood pressure cuff?
Yeah.
What's better?
Yeah.
So actually, if you go to the AHA website, there's a thing that says validated BP, and then they've got a ton of them. I basically say, get a machine, preferably arm rather than wrist or finger, and one at a place that has a good return policy, and bring it in, and then we check it. But most of
I
them.
will never forget that day, by the way, where you're
I think I was joking, right?
but
Maybe I wasn't.
But it made a point, is that
Yeah. So, but that's what I hope your next one worked. I can't remember.
What's the website?
I said I hope the next one you got worked.
No, but the website again?
American Heart Association
Okay.
website is a great, resource for patients and physicians, and you can look up best blood pressure machine. They have some.
I have just generally recommended Omron just because it's very common, and I'd say in calibrating those cuffs over the years, I've had only a few that are just wildly inaccurate. And the other thing to remember is that blood pressures are a moving target, so you really have to do it close time. Like I'll be ready with my blood pressure cuff in the office. They check it, take it off, same arm. They're still sitting there, check it like immediately, and then if it's 20 points off, that seems like that's too much to have changed that quickly. But
And you can't have your blood pressure checked at home, show up at the doctor's office and say, oh, it was similar at home, so it's probably the same. It's really got to check it in the office.
Okay, we're going to go here, and then the woman with the orange sweater. But there's still a woman back there. Raise your hand, Jill. Can you get that mic back from her when she's done? Back to that woman. And then I think at that point, we're probably going to have to call time because we're really, I think we've gone a little over, so I want to be respectful of everybody's time. So go ahead.
I forgot. Are you ever concerned if a patient, I've been known to do this, has overdosed themselves with their blood pressure medicine so that then they have low blood pressure? How dangerous and how would you fix it?
So complex question, because it depends how much blood pressure medication one takes, what the blood pressure medication is, what the difference is between the blood pressure normally and the new blood pressure. So of course, we do.
There would be, but we wouldn't prescribe it in that situation.
I mean, we do have pills that can increase blood pressure, but very often what we do is we get you into the clinic, we try to figure out if it's a blood pressure, for instance, if it's a blood pressure pill that also decreases heart rate and blood pressure, if it's a blood pressure, and kind of how the mechanism of the medication works, and we try to make sure you're safe. No. Yeah. So, and most of the time, everything's fine, so everything's fine. But we'll get you in the office, we'll make sure you're safe, and
Okay, the woman in the orange, and then we're going to the way far back.
I just have a comment to make. I know that a lot of times I think my blood pressure is high. I get this really full feeling in my head. Have any of you heard any other patients say that? Where I think my blood pressure is high.
But maybe Robert?
Yeah.
No?
I mean,
I've heard,
have
we've heard that.
Yeah.
We've heard, maybe counterintuitive, but we've heard, I feel dizzy, okay, for instance, or I have fullness in my head. That's definitely, blood pressure is high, you feel full in your head. We see that all the time, actually.
Okay, we're going to go way in back.
Hi. Yes. I'm wondering, maybe I'm opening a can of worms here, maybe you've already been here. AFib, how does that play in?
Very important question. Very
well,
important question,
hypertension is a risk factor for atrial fibrillation. So atrial fibrillation doesn't cause hypertension, but hypertension can cause AFib. So that's kind of the, how that would be related. Yeah.
And probably in part how that works is that when the heart's pumping against pressure, like I said, the left ventricle can thicken. The pressures inside the heart can then become elevated in the left ventricle. The atria are thin-walled structures, and so if they get higher pressures, they're going to get larger. And a larger atrium is one of the big risk factors for atrial fibrillation. So it's more complex than that, but that's probably why people with higher blood pressure are more likely to get atrial fibrillation.
And what's the percentage of time that one can have AFib and not worry about it so much?
You said bag of worms?
Yeah, something like that.
It's really a complicated.
That would be
hard to tackle.
That should be our next symposium.
Yeah, that was the symposium last month, actually.
You're welcome.
Yeah.
But I think one thing is, as you're measuring the blood pressure, very often the blood pressure cuff will tell you your heart is irregular. So it'll measure your blood pressure, but it'll also say, I'm picking up irregularity. And that can be atrial fibrillation, and you don't want to miss that because it can cause a stroke. So they're actually very closely related. Yeah.
All right.
So that's something you would definitely want to talk to your healthcare provider and confirm that your watch is accurate, and then get appropriate attention for that.
Okay, good.
All right, so we're going to wrap up now. I'd like to once again thank you for attending the seminar tonight. We encourage you to provide us with feedback about tonight's presentation by filling out the card in front of you. And you can provide feedback if you want to speak with any of our, and if you want to speak with any of our physicians, you can check a box next to their name, and I think that that indicates that they'll get a phone call. Is that correct? Okay, I'm seeing nods. Please know this doesn't mean you will be scheduling an appointment, but it will mean that somebody will call you back to answer your questions. In the back of the room, Becca Pease, our RN nurse navigator, will be available to meet with you. She's amazing and is happy to answer any of your questions. Again, thank you so much and safe travels, and a big hand for our panelists today.